My name is Ursula Schmidt Erfurth, and I'm happy to share with you the topic, a clinical state of the art of AI in AMD care. These are my financial disclosures. So what are we doing in clinical routine? Usually we look through an OCD on a B-scan base, and that means that we have an image that is a 2D image. In most of the clinical trials that are going on as we speak, central retinal thickness is used for retreatment indication. In the real world, it is often treat all fluid, which guides patient management. If you look on patients that are in such a treat and extend regimen, it's mostly subretinal fluid that triggers retreatment. That has been shown in the trend study by our group. There's another study group, the Australian one, that did the fluid study, and they compared a treatment as rigorous arm where all subretinal fluid was eliminated versus another SRF tolerant arm. That was called the fluid study. And never forget that there's a huge dissensus between investigators, clinicians, and reading centers, which was reported as high as 72% in the CAT study. So what we have in hand for each single patient is a highest resolution 3-dimensional OCT image showing us all the detailed morphological features. This is quite a difference than by looking onto the retina of a patient as we did before OCT. Based on this insight and also driven by COVID, meanwhile, most of the eye doctors in the US have decided that the OCT image is more relevant, and almost half of them are just looking on an OCT. They do not see the patient, they don't look on the retina. This is quite a change, and it comes with a significant risk, as the Moorfields group has shown a while ago, that an automated artificial intelligence-based algorithm, as seen on the left, does come with an error rate of about 5%. So it is not 100% correct. Yet, if you compare this to the performance of highly trained retina specialists and optometrists, always look on the blue columns. Based on OCT alone, the error rate is as high as 24%. That's horrifying. Our group also looked on the meaning and the role of subretinal fluid, and we used the Australian fluid study for this. And we found that at visits with extended intervals, despite residual subretinal fluid, a significant loss in visual acuity occurred the next visit. So yes, subretinal fluid matters. It matters particularly if the volume increases. About subretinal fluid per se, the jury seems to be still out, because what doctors do during long-term follow-up, when either in a PRN regimen or treat and extend, they always treat subretinal fluid, so that subretinal fluid became the driving force in retreatments. But let's not forget that in all of the clinical studies which are ongoing at the moment, central retinal thickness is the parameter that is used for AMD management, despite the fact that by using AI, it becomes very clear that CRT is not relevant and it does not reflect real fluid volumes. So by using AI, the goal is to get to precision medicine for personalized therapy. But first, we have to learn. Classic machine learning and deep learning are the methods that are being used by AI-based image. My group in Vienna has developed an algorithm, the fluid monitor, that is able to identify low fluid. Why is that important? because fluid matters in all compartments. We have shown this in the Hawk and Harrier data by looking at intraretinal, subretinal, and sub-RPE fluid, and the bright lines show you the quartile of patients that have a low fluid volume, while the dark lines show increasing volumes of fluid in each of those departments, and you see progressive visual loss. So yes, fluid volumes matter, and they matter in each compartment. Can you apply AI to real-world OCT images that were taken in a hurry many times per day? Yes, you can. We looked on 400,000 visits in our outpatient macular clinic and were able to identify 1,127 treatment-naive patients that were followed for as long as 5 years. We measured intraretinal fluid in yellow and subretinal fluid in orange using the fluid monitor. And you can clearly see that this is exactly what happens in the real world. Fluid at baseline is lowest during the loading dose, but then in the following 5 years, there is continuous of fluid in either compartment. So what we suggest and what we are doing is not just look at the blank fly-through of your OCT, but use an AI base to have a much better idea about the disease condition. Switch on the annotation device. That will give you the distribution of fluid, intraretinal fluid in yellow, subretinal fluid in blue. You can check plausibility and correlations in the fly-through. Then you also receive the fluid amounts in numbers. This is each type of fluid by distribution, 1 and 6 millimeters, and the exact volume that comes in nanoliters. Of course, there's also a calculation of the change as compared to the previous visits. There is a longitudinal treatment response curve that shows you visual acuity over time as well as intra and subretinal fluid, and disease activity is indicated to be communicated to the patient. So this is how such a treatment looks like. This is a patient from our macular clinic. Intraretinal fluid is measured, retreatment is indicated. At the next time, there is no fluid detected by the algorithm. Then no treatment is performed, and at the next visit, again, you see that fluid has reoccurred. It is 20% less than at the previous visit, so there is a treatment effect, but treatment must be done because there is more fluid seen than 10 nanoliters, which is the threshold for visual maintenance. The same applies to subretinal fluid. This is a patient that has mainly subretinal fluid. You can have a nice en face view on the SRF pooling, and then at each visit you get a precise representation of the fluid. Here you must treat again. Then you see that at the next visit still subretinal fluid is there, but it is 40% less, and this is the last presentation that we have of this patient so far. We can then also very user-friendly and perfectly aligned to the flow of patient management retrieve every single visit on this chart without having to go into the image registry. So AI in the management of neovascular AMD will be able to provide precision medicine for personalized therapy. We can precisely measure retinal fluid, all types of fluid. Prospective studies that have already started will be able to identify what the threshold is for treatment and will allow us to treat dynamically. Fluid that is changing is the one that reflects disease activity. And it will most likely be intraretinal fluid, which has been shown to most intensively impact visual acuity. We can do this in an objective and reliable manner as fast as by a mouse click in real time, anytime, anywhere. Anyone can do this, also paramedics, of course. That works out in clinical studies as well as the clinical routine. Our duty is now to prospectively identify the relevant parameters to guide treatment in the most precision type approach. Avoid over and under treatment and make this perfect treatment and diagnostic tool as beneficial for the patients and doctors as possible. Thank you for your interest.